recording.
Thank you so much. Excellent. Thank you so much, Trudy. I have been in correspondence with Trudy now, I think, for the better part of the past 6 months, off and on. She's engaged in several of our more sort of national webinars, and I want to thank her personally for arranging this and for hosting us this afternoon. And I certainly want to thank everybody for being here. I think we have a tremendous community that's joined to hear a little bit more from Ben Locke specifically. So let me take a moment and introduce myself, and then I'll turn it over to Ben. So my name is Jennifer Davidson. You may hear Ben call me Jen. Some would even say we're like the Ben and Jen show.
We are.
And my role here at Together All is the Vice President of Higher Education. And in this role specifically, I lead the work that we're doing in higher education, and specifically in the work that we're doing in North Carolina. So you certainly may have received some emails from me personally in the past, but our goal for today is to have a very open discussion around what the landscape of student mental health is now, and particularly in the view of what the broader crisis narrative has meant for community colleges, particularly in a post-TOEFL world. And I'm thrilled today to be joined by Ben, who is our Chief Clinical Officer. And I won't steal any of his thunder, but we're really pleased to have you all here. Please join the conversation, ask your questions, come off mute, post them in the chat forum. And if we can't answer all of them, we will certainly send some thoughts after our time together. So without further ado, Ben, if you want to introduce yourself.
Sure. Thanks, Jen. Yeah, and I think the correct term for when we present together is the Benifer Show. Or something like that, right? Isn't that
That's right.
Isn't that the right term? Hi, everybody. Good to be with you. So my name is Ben Locke. I'm the Chief Clinical Officer with Together All. I've been here about 2.5 years. For a bit of background, I'm a licensed psychologist living up in Pennsylvania. And prior to joining Together All, I've been in mental health since about 95 in one form or another. College student mental health since 2001, and then I was at Penn State University for about 18 years in various leadership positions there, ultimately leading the services across the Commonwealth, so 25 campuses and about 100,000 students. And while I was there, I built something called the Center for Collegiate Mental Health, or CCMH, which is a grassroots practice research network of college and university counseling centers. Today, it represents about 825 colleges and universities. And in the last couple of years I was there, we were building something called the Clinical Load Index, which we'll talk a little bit as we go along today. It's essentially a common metric for understanding college and university mental health services, to be able to talk about them, compare them, evaluate. And one of the things we did while we were building that was we audited and talked with hundreds and hundreds and hundreds of colleges and universities about their systems and services. And it became really apparent to me during that process that there is no answer to college student mental health. There are strategies that institutions employ, and the strategies have to fit the resources, and that you have to cut your cloth, so to speak, to fit what's in front of you. And so moved over to Together All in search of building new mental health support systems that are scalable to populations and that are less focused on the one-to-one service. Of course, as a licensed psychologist, I'm still a profound advocate and believer of treatment systems, that we have to build and advance those at the same time. But because there's no answer in the immediate future for even staffing of one-to-one services or even licensing enough people to meet the demand, population services have to be part of that solution. So what I'm going to talk to you about today is this idea of a crisis narrative, maybe becoming aware of what the crisis narrative is, and also understanding the implications of that in a post-HERF world, where a lot of community colleges had an infusion of funds that offered a whole bunch of new opportunities. In many cases, that funding's gone away, and now we're having to return to kind of the roots and cutting the cloth to fit. And so trying to talk about that. Also, the concept of alignment is something we'll spend some time on today. What is alignment around mental health services within an institution? I'm a very flexible presenter, as Jen knows. So, throw fruit, throw questions, put them in the chat, interrupt, come off, turn your camera on if you have questions. If anything doesn't make sense, I want you to please ask in the moment, so we can make sure that it does make sense for the balance of the presentation. I will share my screen here if I can. Hopefully that's coming through. Yeah. The last week or so, every time I shared something on screens, my computer would crash. And I think I've got it fixed. So everybody bear with me here. Okay, here we go. Crisis narrative. So this is, I'm going to walk through a bunch of slides here about this thing that I call the crisis narrative. This is a presentation that can take 90 minutes to go through. So this is going to be a like strap on your seatbelts version of that presentation. So the way I think about the crisis narrative in college student mental health, it's sort of the current dominant narrative in society, in culture, about the way we talk about mental health. And we're going to get into some of the details there. I believe that what's actually going on is far more complex than a quote unquote crisis. And when it comes to implementing support systems, you cannot behave as if it's a crisis because it's not effective. And so what we're going to do is explore the elements of the crisis narrative, and then how to think about strategizing around mental health services. Just to be really clear, as a person who spent a lot of time, provided a lot of treatment, what we're not talking about today is the individual. So individuals absolutely experience crisis. They are in crisis. They're coping with life crises. That's not what we're calling into question today. What we're really talking about is the sort of macro exosystem level of society and the narrative that has evolved over the last 20 years or so about mental health and student mental health. And what's important is that we don't usually control the evolution of meso-exosystem or macro system exosystem narratives. They develop on their own, and then we are exposed to them. So part of what I'm trying to encourage people to do is to begin critically engaging with this narrative when it presents in your world and not just reacting to it in an ongoing way. And I personally saw a lot of that overseeing a large mental health service in across many campuses. So we're going to walk through kind of 6 ingredients that I think provide good examples of how the crisis narrative is manifested and how you might see. And this will be pretty quick. And I'm sure that each of you will come up with ideas on your own that might flesh out or provide more examples. And I won't be able to cover everything here. So the first one just to talk about a little bit is advocacy and interventions. So a really important thing for us all to be aware of in terms of the student mental health picture we're facing today is that the last 20 to 25 years have been nonstop advocacy and interventions around mental health. And frankly, it goes back to the 1900s. But if we really think about, for example, the Garrett Lee Smith Memorial Act, passed in 2004, funded in 2005, hundreds and hundreds and hundreds of millions of dollars invested at a federal level. We have state laws being passed, mandating and advocating for certain services. There are literally thousands of foundations in the US now around mental health, the JED Foundation, for example, and many others that have been advocating. Of course, faculty and staff are advocating, students are advocating, and those responsible for mental health services are advocating. All of that is well intended. All of that is intended to improve people's lives and their experiences and their access. But all of this advocacy has not been coordinated, and there are complications that are beginning to evolve, and we're starting to see some of those happening. And one of the questions that's important to ask around advocacy is, what is the goal? Where is the goal post? How will you know when you get there if you're advocating for something? And mental health, as it has evolved over the last 10 or 15 years, 10 years especially, has no real beginning and no real end. And so as we think about advocating for mental health services, it's important to ask the question, where is the goalpost? What are we trying to achieve, and how would we know when we get there? And what we've seen in the advocacy space around mental health in a lot of cases is that, for example, foundations that start off focused entirely on suicide prevention end up becoming quite generalist in nature, expanding. JED Foundation is a good example, expanding into high schools, expanding into sort of mental health as a whole, building holistic well-being approaches to institutional and student well-being. That's not what they started out motivated to do, and that evolution helps to maintain their relevance as a foundation, but also continues the sort of chant of advocacy. So we could go into tons of examples there, but we'll skip on to this one. So pathologizing normality is a way that lots of folks in the mental health treatment space, mental illness treatment space, have been very concerned with the evolution of diagnostic categories, the expansion of the DSM, Diagnostic and Statistics Manual, and the inclusion of more and more and more normative life experiences as symptoms of diagnosed disorders. Of course, you can't get treated under insurance without a diagnosis in most cases. And so diagnoses are used for normal life experiences in order to reimburse services. And then we have this sort of popular culture shift where increasingly people are very willing, as a consequence of reducing stigma, increasing help-seeking behavior, to identify as, hi, I'm Julie, I have anxiety. Or if you're on TikTok, if you have these 3 things, you might have anxiety. Or if you experience this, you might be depressed. So we have this sort of society-wide pathologizing of the normative human condition, which we can assume will include distress, will include suffering, will include grief, will include loss, will include sadness and anxiety and worry. All of those things are part of the normality. And as a consequence, we've ended up in this space where people are very willing to self-identify as having a disorder or being disordered in some way. And that creates lots of challenges. Transitioning to number 3 here, one of the other big themes, and I could spend all day talking about this in particular, is the sort of surveyification of research. So over the last couple of decades, online surveys, web surveys have become a thing. Anybody anywhere can create data through running a survey. But in the course of freeing up that mechanism, we have a loss of rigor and fidelity and methodological accuracy. And so we have lots and lots. It's very easy for people to produce charts and response findings, if you will. But what we often don't talk about is the non-response bias that comes with that. If you ask 100 people to participate and only 8 join, you have 92% of your sample who didn't engage. And a lot of times the way that findings, sort of informal survey findings, are shared as is if they are a fact, or as if X% of people endorse one item, that means they're depressed. And in fact, it couldn't be farther from the truth. And of course, who you ask matters a lot. And just to give you one example that we observed in CCMH, and Jen has heard this example before, but one of the standardized items in CCMH, so that counseling centers ask nationally, internationally, is, in the last 2 weeks, I've had thoughts of ending my life. So students are answering this question from 0 to 4. The average endorsement of that item greater than 0 is 40%. So 4 out of 10 students are endorsing the presence of suicidality, thoughts of ending my life, in the last 2 weeks. That feels like a crisis. If you then, this system then asks the clinicians if the student has presented with concerns of suicide, and the prevalence of that drops to about 9%. So you see a 75% relative reduction in prevalence based on who you ask and how you ask it. And one of the things we're seeing very clearly in surveys is that students and people answering surveys, but especially students, will endorse lots of items all over the map with all kinds of potential concerns, especially when you think about the identification of mental health concerns. And as a clinician myself, I would routinely sit down with students and say, so you endorse this item about thoughts of ending your life. Like, oh, no, I didn't mean that. I thought you meant this other thing. Like, okay. You endorse this item of losing touch with reality. Oh, no, I didn't mean that. I thought you meant this other thing. It's all kinds of things that happen in self-report that are not fact. And so one of the aspects of the crisis narrative is the surveyification process, and data being trotted out as if it's fact, as if it represents the presence of a disorder. This slide as well is an all-day presentation, practically, but in a nutshell, our modern media has moved from a model where you have a subscription and you read whatever they give you, to a model where they pay per click. They get paid per click on their article. So they produce articles in order to get clicks. Let's see, we have a good question here. Couldn't that also be so this is Barb O'Donnell asking, couldn't that also be because students feel more comfortable answering a survey versus admitting to someone in person that they're having these thoughts? It's a great hypothesis. The experience that I had in person is we would look at what the student responded to, and then we would talk to them in a therapy room where we had 50 minutes to talk with them about all of the details. And so those clinicians that are evaluating the students have spent an hour evaluating them and are concluding that suicidality is not present. So yes, of course, part of the promise of surveys and anonymity is maybe people can be more honest. And there surely is some of that happening. What we see in practice, though, is that there's a lot of misunderstanding and misinterpretation of what's being asked. And the other part is, in a huge non-response bias where 90% of your invites don't participate, the people who do engage in the survey tend to be emotionally connected to the topic that you're asking about. So they're much more likely to respond affirmatively. So in the social media, in terms of the crisis narrative, social media has transitioned from subscription to pay-per-click. So their entire focus is getting you to click on their article. And of course, social media exists solely for the purpose of capturing and retaining your attention. And if you haven't watched The Social Dilemma on Netflix, you should certainly take some time to do that. And yeah, clickbait titles, exactly, Kendall, is what's happening. And in a crisis narrative framework, what we see is that media will pick up on research that has a crisis finding. Researchers are then reinforced for producing crisis findings, and you get into this cycle. People in social media, influencers, are reinforced financially for getting people to sign up. And when you pathologize normative human experiences and get people to sort of connect to that and click on it, everybody benefits in that cycle, except for the people struggling with the concern. And what we've seen in both media and social media is that those trends are able to influence human behavior, so that brand new behaviors are exhibited by people who would not have exhibited them otherwise. There's an amazing study around the spread of Tourette's and tics through TikTok, which is really worth Googling and looking up. Essentially, really pretty extreme behaviors can be kindled through media and social media. So all this fits into the crisis narrative. Both media and social media benefit through the advancement of that. If you have any doubt about, is mental health crisis a new trend, relatively speaking, yes, it is. At least Google says it is. If you look at their search history, the rapid rise in mental health crisis began around 2013, 2014, which was exactly the same time I began to get tons of calls from investors and businesses looking to build businesses to attend to this crisis. And it has just kind of continued from there. Oops. Industry is a key player in the mental health crisis. And one of the roles I play at Together All, as Jen can attest, is that I have a pretty firm rule that we do not sell our business based on a mental health crisis. We have a very clear social impact charter. We're here to help as many people as possible. We believe that all people need support. at some point in their lives, and we're trying to build new mechanisms to achieve that goal, but we're not here for a crisis. What we do see in lots of businesses, though, is leading with crisis narratives. Did you know that 30% of your students are suicidal? It's a crisis. Did you know this? It's a crisis. And of course, if you look at things like the pharmaceutical industry and the efficacy of medications for mental health in mild to moderate cases, like we could talk all day about the role of industry in promoting and maintaining a sort of a crisis mentality toward mental health. So all of these are ingredients and contributors. The last thing that I'll touch on in terms of ingredients in the narrative is language and subjectivity. So when I was starting my training in the mid to late 90s, right around that time, a book called Girl Interrupted came out, subsequently followed by a movie. Soon after that, the incidence of self-injurious behavior, specifically cutting, began to rise really dramatically. And what was interesting is it began to rise outside of the typical diagnostic categories where you would encounter it. What we have seen today, or since then through today, is the absorption of psychological jargon, professional mental health terms and diagnoses into the general population. So teenagers talk about depersonalization, derealization, and very specific kinds of symptoms. And that absorption of professional jargon to describe routine human experiences creates the impression that we have this explosion of depression or explosion of anxiety, when in fact, people have just changed their language in some ways. I'm not saying that it isn't the case that more people are experiencing these things. What I'm saying is that more people are using psychological jargon to describe routine human experiences than they were ever before, and that has an impact when that sharing of language happens through media and through social media and through influencers. That actually does generate contagion. And we know that's the case, for example, with very extreme behavior like suicide. When I was working in community mental health in Boston, we had a suicide contagion event in South Boston, specifically young teen males by hanging. And it was very, very difficult to intervene with. And that was just a specific localized contagion of very extreme and tragic behavior. If you scale way back from that to the experience of anxiety or worry or sadness, and then categorize it as depression, and you put it out on social media, you can imagine how that would begin to influence people. The other component of this, which is even trickier, is subjectivity. So it's very, very difficult outside of a therapy room to say to somebody, actually, you're not experiencing a mental health problem. What you're experiencing is anxiety. Everybody has anxiety, and this is what it looks and feels like. But it's very difficult to sort of say to somebody, that's not a mental health problem, and that is. And that subjective assignment of mental health diagnostic criteria is a very tricky area that helps to drive the crisis narrative as well. Because actually moving beyond that either takes a therapy room, like a prolonged conversation with a person, or cultural change, both of which are actually fairly tricky to do. So those are kind of the ingredients of the crisis narrative, and I'm going to touch on a couple of other pieces coming up here. I just want to take a pause just for a minute here to see, before I move on, any questions or comments, observations? So we have a comment here from Eric. Probably a very important question: is the crisis narrative positively affecting the rates of actual diagnosis by mental health professionals that are buying into the narrative? Absolutely, I would say. Yeah. So when people come forward saying, I am depressed and I'm experiencing difficulty sleeping, loss of interest in activities and relationships, things I used to find pleasurable, they go tick, tick, tick on the diagnostic sheet. And if you add to that, the only way you can pay for mental health treatment in most cases is through insurance, which requires a diagnosis. So you're going to see that happen as people come forward seeking treatment. You have to verify that in fact that exists. Yeah, and so this increase in seeking out of services is part of what we're seeing. Okay, so I'm going to keep moving here. I mentioned this before, but what's your goalpost? So if you look at the percentage of people in the last year who had serious mental illness, it's about 4.5%. That number, by the way, has been stable for 40 or 50 years, hasn't really moved. If you look at the average counseling center utilization, typically not in a community college environment, typically, but let's say it's about 12%. Is that your goal, to treat 12% of your population? Is it the percentage of the student body who screens positive in a survey, 50%, 60%? Or are you trying to support 100% of your population? What is your goal? And this starts to get into where mental health and the crisis narrative is very problematic, because if you're always just having a knee-jerk reaction to the latest crisis narrative manifestation, it means that you lose track of your goalpost and the resources you have to reach that goalpost. So I'm not going to go too deep into these next couple of slides, but these are a number of ideas for how you move beyond the crisis narrative. And this group of ideas is sort of at the bird's eye level. You know, part of what we're doing today and part of my kind of soapbox in the world right now, in part, is helping to spread awareness that this is happening, and that that you need to be aware of it. So things like number 3, name it, wonder, educate, advocate for alternatives, is an important part of moving beyond the crisis narrative. Number 6 is a really important one: long-term, data-driven, not reactions to each new crisis. And number 7 is something we're going to talk about today, which is this idea of population plus treatment, and that each institution has to come up with a strategy that is aligned with their resources and mission and stakeholder expectations. One thing that's just really important that I like to say everywhere is that educational institutions have a responsibility to educate their students. And that sort of makes sense, right? But part of that should include this crisis narrative, ideas around human distress and seeking support, the labeling of sort of normative distress as mental health problems, and so on and so forth. And that accomplishing those goals requires institutional leadership. So if you have a class or some kind of educational requirement that all students have to complete, that gives them the basics of human experience and struggle and how to overcome, that can be part of it. And the final thing that we'll talk about a little bit more in detail as we go is this idea of the alignment model. So this was something that I was advocating for in my role at CCMH, where what we sort of realized in building the clinical load index is that there is no answer to staffing of a college or university. There is always a strategy that is specific to that institution. And the goal is to align the resources, the mission, the stakeholder expectations, and the reality of the institution so that everybody is in agreement. This is what we're able to provide. This is what we're not able to provide. Where institutions get into a lot of trouble is when they promise a lot of things, but they can't actually deliver on them, or the people coming to the institution expect a whole lot of things that cannot be delivered to them. And again, this requires leadership involvement and transparency of messaging, consistency of messaging. This goes to strategy, essentially. One of the ways that's helpful to think about this is this treatment gap and basic needs image that I'm just going to walk through. So if we assume that 100% of the population has some level of basic needs around mental health and human distress, there's some percent in need. If you follow the Healthy Mind study, let's say it's 50%. Let's say treatment capacity at institutions ranges from almost nothing to 60%, let's say, with an average of about 10. And where whatever level you provide in terms of treatment, you subtract that from the need, wherever you want to hypothetically place that, and that's your treatment gap. So if you treat 10% of the population, and there's a 50% need, then you have a 40% treatment gap. You're not going to make up a 40% treatment gap in hiring one person. It doesn't work that way. And so that's where you have to align your strategy and your model to the realities of what it is you're trying to do. So if you're really only able to treat, let's say, 4 or 5% in terms of actually provision of treatment within the institution, then it's really important that the institution look at a population support system to try to provide everybody with a baseline of support, knowing that the treatment capacity is quite limited. So that treatment gap concept is really useful in terms of determining where do we draw the line in terms of how much treatment we can realistically provide. People, capital, office space, resources, all the rest of it, and then how do we attend to the population with baseline services. A population approach, just to say it out loud, is basic needs, mental health information, resources, self-help, clinical support, and ideally safeguarding that's accessible and affordable 24/7. So in other words, every person can benefit from this population support. It provides a lot of the basics, but it doesn't necessarily provide treatment. And it is designed to prioritize and amplify natural support systems as opposed to specialist treatment systems, which are expensive to implement. This slide is just a quick reference. If you want to go read more about the alignment model at CCMH, the link is right there and it will be there in the slides. And this is just a slide to illustrate, there it is, the kind of how a treatment approach cost structure works compared to a population support approach. And these are very, very rounded numbers. But hypothetically, if you have a counselor plus benefits who's 100,000 and they serve 95 students a year, then each person served would be in the range of about $1,000. Even at the highest end, 120, 150, 180 students a year, you're still looking at a very expensive amount of services, cost per services per person. With TogetherAll as an example, you have a baseline contract, let's say for about 4,000 students. And if you achieve about 2 to 3% utilization, which is a pretty basic bar, then you have a very low cost to support each student. And the key difference here is that each new student you send to a population service keeps your costs the same, but decreases the cost per student served. In a treatment model, each new student you serve dilutes the amount of treatment provided to all of the students or increases your total cost of providing that service. So they're totally different strategic approaches, and the population approach is every time you send another student there, you essentially increase the benefit of the service. And so I really like Anne's comment here. So framing it positively rather than mental health support, can we teach mental fitness, resiliency, tools, social emotional learning as part of a full population approach? Hallelujah. Hallelujah, right? So the problem with the crisis narrative and social media is that by the time students get to college, they've had 15 years of exposure to, if you experience this, you have an anxiety disorder. If you experience this, your depression, it's a crisis, it's a crisis, it's a crisis. They arrive on campus convinced that anything they experience that's upsetting is a crisis. Some of them are genuinely going through horrific, tragic life experiences, and they need our treatment and support that's specialized and expensive to deliver. And we need to try to prioritize that and make that happen. But as a balance for the population as a whole, this teaching of the experience of being human as a whole is a really important piece of that. Okay, so I'm going to transition here for a couple of slides, just talking about the power of peers and community support, which is what our social impact mission is. I think we should have plenty of time to finish up here and have some good questions as you have them. So in the peer support has been around since the dawn of time, since there were two people who could talk to each other. they got peer support. Okay, it's as old as it gets. And if you look back to the origins of AA, 12-step models, even in hospital systems, on a cancer unit, having a survivor who comes back and provides peer support to the next person coming along. You have sharing, supporting, normalizing, lived experience, supporting new lived experience, and that sense of belonging and shared experience. And of course, there are many things that keep people from seeking a physical community at times, such as isolation and withdrawal, stigma, access to that community, and just basic literacy sometimes. What's really clear from social media utilization is that gazillions of people are engaging in online communities, but the key problem is that none of them are safe. None of them are clinically safeguarded. None of them have paths to care for people at risk. And the moderation that exists, if it does exist, is not clinically informed, is not there to protect mental health, and in many cases doesn't exist at all unless it crosses a really egregious line. And I'm sure everybody here has read about the horror stories of people experiencing bullying, trolling, grooming, and other kinds of things in social media spaces. So when students arrive at campus, a thing to keep in mind is they're already engaged in peer support, but all of it which is happening online is not safe. It's not designed to be safe. It is designed to maintain their attention for as long as possible, probably reinforcing the crisis narrative if they engage in mental health. So what we do at Together All is this idea of clinically moderated peer support. So instead of a one-to-one relationship, counselor to student, we focus on the licensed clinicians supporting lots of people at the same time, and then partnering with those who are doing the one-to-one support, whether that's on your campus or in your community. So it's population plus targeted impact. What we're seeing in our community is that the people who do utilize clinically moderated peer support tend to be exactly the people we're worried about. They don't have other supports. They're not seeking other supports. They're generally marginalized communities, and they often have some level of risk, but they're reaching out here. As a licensed provider myself, I'm really wedded to this both and approach of, community is not the solution for everybody, but it is a population solution that can work with treatment systems. And what we're seeing is this growing acceptance of and advocacy for peer support systems, but they're very difficult to actually implement locally. What we do is global in nature, so you get that benefit of that very large community. So a couple pieces to highlight with the Together All community. We're built to be accessible first. So immediate access, 24/7, mobile first. About 50% of our users are on a desktop or a laptop, and about 50% are by phone. So we see both of those kinds of types of engagement. Students join the community anonymously, and that anonymity is enforced by my clinical team. I didn't actually say this up front, but I oversee a team of about 50 to 60 clinical staff who are global in nature, and we have a 3-tier 24/7 clinical structure in place to take care of the community, shape the community, and care for people who might be at risk. One of the things we do there is enforcing anonymity at anything below the country level. And the reason for that is to make sure that trolling, bullying, grooming, those kinds of things don't happen, but also to keep the focus on the mental health concerns, the shared lived experience, instead of identities and locales and that kind of thing. So we are 24/7 clinically moderated. We have this risk escalation process that's very rigorous. And when a student joins our community, 4.5 million other students are also able to join that community, coming from about 450 colleges and universities, which is something you can't achieve if you build peer support at one institution. It's really that power of scale which helps to make it work. And so as I go back to thinking to where we started, the crisis narrative think this is our last slide. Yep. So get your questions ready. We're going to move into just open discussion time here. It doesn't have to be a question. It could just be an observation. Just trying to kind of bring everything around. Part of what you all are experiencing at your campuses in relation to mental health and student distress is tied to this crisis narrative, which we sort of did the super quick tour through. And one of the challenges in any college or university, including community colleges, is figuring out where do you set the bar, the line between treatment and population support. And as we think about the crisis narrative, it kind of constantly creates this drumbeat where somehow you have to provide all the treatment that everybody wants and everybody needs treatment immediately. And part of what we're trying to do is say that's actually not tenable. I know that's not tenable, and I'm sure you do. But then what we can do is attend to the population of people by providing baseline services that are accessible to all. And that's that is a very realistic institutional strategy to say, this is what we're able to do, this is what we can provide, and then aligning your whole community around that reality. All right, I'm going to stop talking and would love to hear comments, questions, and just kind of talk from this point forward. I see some flickering of names out there. I have a hand up, Eric, I think. And Trudy, if you want to run this portion, I'd be happy to hand it off to you as well.
No, I was just going to say, this is everybody's opportunity. Ben, you've done a wonderful job explaining, the issues with students' mental health, the crises or lack thereof. And it really is important that, if your college does not have any supports for our students that are going through mental health issues, this is the time to ask questions to Ben or Jennifer. I looked this up, this service up, and it's one of the leaders in the nation. They serve a lot of universities and a lot of colleges. And so, if you have some specific questions, you've got them right here. And now's the time to ask them, or to even, find out, if, the resources on how to get more information. So please take advantage of this right now.
Yeah, Ben, this is Eric at South Piedmont Community College. Just
Hi,
a couple
Eric.
of, hi. Thanks for doing this. I imagine my colleagues and me probably have felt the rumble of this crisis narrative, but it's hard not to buy into it yourself for a while, especially during COVID. And I don't know that there's any amount of research that'll ever convince people that it almost felt like the world was imploding for a minute, but
Yep.
I guess a couple things I wonder about is, first of all, it's almost a paradox in a way, especially with our younger students. This is their space now, online and in these digital communities. What are you seeing as, I'm sure it's limited, but what are some of the results you're actually seeing? What positive effect is this new approach, from your research showing?
Mm-hmm. Yep. Well, we have a document on sort of the evidence, sort of the case for peer support, which we can provide, which kind of walks through a lot of the literature on peer support in general, where it comes from. And to some extent, the online space is the next generation space, but also we serve lots of folks who are not in colleges and universities. So in the Together All platform, we have the full developmental diversity of perspectives on experience, and we see that playing out in the community. One thing we did recently was we wanted to look at the Together All community objectively and ask the question, is it a therapeutic space? And what we did was we used an outside company that evaluates traditional counseling sessions for adherence to motivational interviewing and other techniques. And we sort of gave them all of our data and said, analyze it and tell us what it looks like. What we found is that the community has all of the same therapeutic ingredients that you would find in a traditional counseling session in different amounts and mixtures. The Together All community is a little more focused on sharing personal, like shared lived experience and stories, a little bit more on validation and advice giving, and less on things that you might find in counseling like structuring or facilitation or complex reflections. And so what we're finding is that students are already online, and a lot of times, Jen, I'm thinking of the number of students who have shared something for the first time.
It's over 50%.
It's over 50%. So in terms of people coming into the community sharing something, about 1 out of 2, it's the first time they've shared it. So this is sort of their native space. It doesn't take them a lot of time to orient and get plugged in. And it is generally the people who are not seeking services elsewhere who are, I think, deriving the greatest benefit, because they know how to plug in. They're not worried about being identified in some way, and they're able to move through it pretty quickly and get a therapeutic support.
I'm wondering, Ben, if you could also speak to sort of how we are sort of getting the feedback from our members directly, like how we're thinking about gathering data that would help demonstrate from the members what their impact of the community is on them.
Yeah, so we one of the things we have running in the community all the time is a question about how has Together All impacted your mental health, and what we find from that item is that about 85 to 87% of college student members indicate that Together All has been helpful to their mental health. So that's been a pretty compelling number over time, and there's some differences in terms of who engages in what ways, in terms of how helpful they find it, that kind of thing. But generally speaking, that's about where it's landing. So great question.
Yeah, Ben, thank you for speaking to that. And then the other thing I wanted to ask, and I'm sure it's on many minds, is walk through how this actually works. You know, you've got all these people on this community, and you've got clinical moderation. How does one identify or see, or what kind of red flags are you looking for, and how do you get that person to agree to step out to a more individualized setting where you can maybe engage them and begin to bring them into treatment mode?
Yeah, sure enough. So I know that people who want kind of in-depth tours, that we can set those up and walk through, but I'll provide a brief description now. So one of the key things to understand is that each institution that we partner with, we develop a customized risk management plan for your students. So it would include your resources, your contacts, the pathways that you want us to follow if there's a student in need. And we have sort of a universal approach that we employ if a student needs like a crisis evaluation, that we have a risk escalation pathway through a group called Protocol, the 24/7 crisis service that will make an outbound call to the student. So that is employed for every institution that joins. This customized risk management plan is put into place. In terms of the way it actually works on the platform, students join the platform and then begin contributing, and they can contribute in a public community. They can contribute via a comment to another post. They can develop friendships on the community, sort of one-to-one or one-to-many messaging, also anonymous. They can use a journaling tool, a goal setting tool, self-assessment tool. All of that content that they might generate, along with things, questions that they answer during sign up, is being churned through by the technology on the platform, which is then alerting my clinical team, hey, you should go look at this, possible risk to self, anonymity, and they're just, 24 hours a day, 7 days a week, working through those. And just to offer a little bit of nuance there, because my whole team is licensed clinical providers and all moderation is done by licensed clinicians, we actively work to shape the content in the community so that it's appropriate. We're not just hiding things. So if somebody's trying to engage on the topic of an eating disorder or suicidality, we will then, I'm going to go ahead and share again, Jen, so people can see your email. We will go ahead and work with the member to adjust or shape that content so that it can be appropriate. If they're talking about a very difficult thing, we want it to be able to stay in the community. So the clinical team will work with them. And if we feel like their risk or their distress cannot be managed within the community, then it goes through what's called an escalation within my team, where it goes up to the senior clinician on duty, and they work like an intensive case manager off platform. So they will activate your sort of custom risk management protocol. We will send them through a crisis line. We'll work with a domestic violence shelter. We'll call their physician. We'll call their psychiatrist. We'll call and interact with anybody who's needed to help them get where they need to go. And part of our approach is, because it's an unregulated space, we're not providing traditional services. We've internally adopted a duty of care ethic in the escalation process, so that if somebody is escalated, we assume a duty of care until we have confirmed handoff of the baton to the folks who they need to get connected to. So that's kind of a brief description of how we do what we do, including catching possible risk, shaping the community, and then handing off to the next level of services.
Thank you. That sounds like quite a feat to do all that, but
it is. Let me tell you, it is.
It
is. But it is, I'm here to pursue new ways to take the expertise of licensed providers and scale their benefits to populations. So it's this kind of marriage of clinical expertise, technology, and then peer support, the sort of therapeutic mechanism.
Dr. Locke, this is
Yes,
Karen
hello.
Mosley. This is Karen Mosley from Durham Technical Community College. I thank you for this. Thank you, Dr. Hughes. This is fantastic. Do you have a list of community colleges that you work with handy?
I will let Jen tackle that one.
Hello, Karen. That's something that I could share. Yes.
Okay, great. Thank you.
And Karen, whatever, Jennifer sends out, when you'll get a copy of the PowerPoints, but she can also send out that list as well. And I'll send it out to the listserv as soon as I receive it. So, and also a copy of the recordings as well. Okay.
Fantastic. Thank you so much.
You're very welcome, Karen.
Yeah. We have a question in the chat from Anne about how do colleges convince students to make use of the services. So going back to a little bit of what I was talking about early on around institutional leadership and institutional commitment to the strategy that you employ. When you employ a population service approach as part of your strategy or as your primary strategy even, the institution assumes primary responsibility for getting the message out. We provide, and Jen knows much more about this than I do, but we provide all the materials that you need to do that reach out to students, including strategies that we know that work really well for reaching students. And I think as part of that, institutions, I always encourage that you to be thinking, now that we know about the crisis narrative and we know about help-seeking behavior and what we're trying to do, what's our 2 to 3 year strategy to shift that narrative internally, re-educate students as they arrive, and point them to the services that we are offering at the population level. Jen, anything else you want to offer there?
Yeah, no, I would just echo what you shared, Ben, that we have over the past 2.5 years have really honed in on how we help students engage within the community and meet students where they are. And that would be part of the onboarding that you would receive from Together All. And of course, on the back end, data related to that engagement.
Yeah, and there's another question in the chat from Kindle here about minors. So our platform is 16 plus. So assuming that you don't have lots of students who are less than 16 plus we're able to serve. And I think that would be a pretty good match for most of those early folks coming through.
And,
I see
and Ben,
we are, I'm
Ben,
sorry, go
that
ahead.
comes from, you know, people, we have a lot of colleges that have early college and college and career promise. So
Yep.
we serve
So
a
that's
lot
a
of
good
students.
match.
Yeah, that's
That's
why.
a good
That's
match.
a good
Yep.
question.
Yep.
Right. Well, I would say we're out of time, but again, I want to thank Ben and Jennifer for this wonderful presentation about Together All. If you are interested in finding out more information, their contact information has been posted in the chat. And you can reach out to them and get more information on what their service provides. And again, thank you so much for providing this and spending your time with us. Greatly appreciated and greatly needed. So
Thank you, Trudy.
Everybody have a
Everybody
great
have a nice
day.
afternoon. Take care.
Thank
Thanks,
you very
everybody.
much.
Be well.
Bye-bye.
Bye now.